Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. We are continuing on with the top 200 drugs where I'm highlighting some of the most important clinical practice pearls as well as some of the most important things that are going to show up on exams throughout your career, whether that be board exams or pharmacology exams and classes. So that's my main focus here with the top 200 podcast. A lot of have requested that specifically. Reminder that I have done over 300 medications in the past archives, and I've done all of these that you're going to hear today in depth in 10 to 15 minutes each. So go to the reallifepharmacology.com website. You can find them all there, as well as on your favorite podcast platform. All right, without further ado, let's get into the top 200. We'll go number 61 through 65 today. First medication is Suboxone. That is the brand name. It is a combination of buprenorphine and naloxone. And the primary indication I've seen this used in practice is for opioid use disorder. So as you could tell from the combination, it is two medications. So the first medication is buprenorphine, and this is a partial mu agonist. It binds tightly to opioid receptors, and in doing so, it reduces the likelihood that a full mu agonist, such as fentanyl, morphine, heroin, will be able to bind and have its full effects. So basically, in opioid use disorder, it really tries to blunt the effects if a user is going to try to utilize some of those full mu agonists. So, prevents that reward, euphoria from other opioids. Now, what about the naloxone? So, naloxone, if you've heard many things about medications, and in the news, naloxone is a medication used to treat opioid overdose and obviously help reverse some of those symptoms. But why is it in this combination? Well, essentially it's been put in there to prevent or deter abuse potential. So users potentially trying to dilute this medication, turn it into a solution and inject it, for example. That's really the primary reason why naloxone has been put into this combination. So this combination will potentially precipitate, or it's a lot more likely to precipitate opioid withdrawal compared to using like a full mu agonist like methadone in opioid use disorder. So that is a potential downside there, particularly in patients who are taking significant amounts of opioids in their addiction. So that's something to pay attention to there. It can be started. This medication can be started prior to full withdrawal. And of course, this is a controlled substance. It is a Schedule III controlled substance with that potential to cause some partial mu agonist action there. Adverse effects, typically it's been pretty well tolerated. There may be some concerns with hepatotoxicity or at least concerns with using it in patients with moderate to severe hepatic dysfunction. So that's something to pay attention to there. There have been some associated, obviously, opioid adverse effects, so potential for constipation, of course, respiratory depression, and then those withdrawal symptoms, which I alluded to before there, where you can get sweating, you can get nausea and vomiting, some achiness. Those are all common symptoms associated with opioid withdrawal. There have been some rare effects on the teeth and some potential increase of decay and dental cavities and things. So that might be something to pay attention to with as well with the use of Suboxone. All right, let's move on to the next medication, and that is Lisdexamfetamine. Brand name of this medication is Vyvanse, and this medication's primary use is in ADHD. Mechanistically, this medication is a sympathomimetic medication that stimulates the release of norepinephrine and dopamine in the central nervous system. And obviously that can potentially have some benefits in the management of ADHD. It is a controlled substance. It's a Schedule II controlled substance. So again, that's the highest risk for abuse and diversion. And the adverse effect profile of Lisdexamfetamine, as you could imagine, it kind of ramps you up. So insomnia, and particularly in pediatric patients, if we're using this for ADHD, weight loss, poor growth. So those are things that we definitely need to pay attention to. A good example I came across in practice the other day was we've got a patient taking supplements, a younger pediatric patients who are needing kind of supplemental Ensure type products where we're giving supplemental nutrition and they're taking a medication for ADHD. So we've got to pay attention to that. That's an important thing, certainly, in our pediatric patients with regards to weight loss and ensuring that patients are having a good growth profile. As you could imagine, with ramping people up, cardiovascular concerns we need to pay attention to. So elevations in blood pressure, increase in heart rate. Also, some tics can happen with the use of stimulants like this. Risk of diversion, of course, and priapism has also been associated with the use of a medication like Lisdexamfetamine. The insomnia piece, the later we dose this medication in the day, the more and more likely we probably are to cause insomnia. So pay attention to when the patient's taking that. That can be a good patient education point if you see a patient asking about taking medications for sleep, that type of thing. Be sure to look at that medication list, look at the timing that they're taking those medications, and making sure the ADHD medication isn't causing that issue. All right, moving on to the next medication. We've got number 63. That is Nortriptyline. Brand name of this medication is Pamelor, and this is a tricyclic antidepressant. Historically was created and used for the management of depression. I don't see it used terribly often for that anymore. I'm probably more likely to see it in certain types of pain syndromes, such as fibromyalgia, neuropathy. Occasionally I see it in migraine management. In the management of depression, Nortriptyline is unique in that we do have target drug levels for this medication. So they are usually that target is 50 to 150 nanograms per mil. So that definitely differs from some of the other tricyclic antidepressants. Again, this medication is not typically used first line because we've got a lot of anticholinergic adverse effects. as well as cardiac complications in the situation of overdose. So, as you can imagine, patients with depression, they may be at more risk for drug overdose and taking too many pills. And if we do that with nortriptyline, we have much greater overdose risk, particularly with cardiac function, compared to the use of, let's say, SSRIs, which are now more commonly used in the management of depression there. So, being highly anticholinergic, I want to run through some of the common adverse effects there. So, can't spit, pee, see, or poop, so dry eyes, dry mouth, constipation. We can have some fall risk. We can cause some urinary retention. So, particularly patients with a history of BPH, that can add to that urinary retention issue. Great example of the prescribing cascade. So, where we start a medication like nortriptyline, and then we add other medications to treat side effects. So, dry eyes. So, if you see artificial tears, it's a good indication that somebody may be taking an anticholinergic medication. Saliva substitutes, constipation medications, your Sennas, your Docusates, your Miralaxes, confusion. So if you see a patient started on a dementia medication, you better look at that med list and make sure they aren't taking an anticholinergic medication like nortriptyline as well. Nortriptyline, I do want to mention, is potentially a little bit better tolerated in the elderly compared to an amitriptyline, for example, within that TCA class. There is some evidence for that. A couple other things. QTC prolongation risk, that's something to pay attention to, as well as sexual dysfunction. Definitely very common with antidepressants in general, and TCAs definitely fall within that category. All right, next medication is insulin lispro. Brand name of this medication is Humalog. As you can imagine, with an insulin-type product, we're going to use this to manage diabetes and bring down blood sugars and hopefully get our patients to their goal A1C. Insulin lispro is a rapid-acting insulin. So that means we're going to typically give this with meals or maybe, just a few minutes prior. And it causes glucose to move from the bloodstream into cells. So essentially storing that sugar away in cells and bringing it out of the bloodstream. Ultimately, that's going to lower blood glucose. Where is this medication used primarily? This medication is used acutely to bring down blood sugars. So that's going to be in the setting of post-prandial blood sugars, so those blood sugar spikes following meals. A rapid-acting insulin like insulin lispro is going to be useful for that. In type 2 diabetes, you may see this used in a basal plus 1 type situation where maybe it's just used with the biggest meal of the day. In type 1 diabetes, obviously, we're using that, in general when a patient eats. And did want to cover sliding scale a little bit here while I've got the opportunity. So this is something that's generally not preferred. So sliding scale insulin is basically getting a blood sugar number and then treating that number. So if you see that number is 300, when you check your blood sugar, now you're going to give a certain amount of insulin based upon that number. And the reason why this is generally discouraged, it's a reactive mentality. That blood sugar is already spiking or spiked, and it's got to that high peak. And so with that kind of reactivity, you're not preventing the high spike in that blood sugar. You're still getting there. And now you're maybe running the risk of, that blood sugar maybe is starting to come back down. And now we're giving that insulin and maybe we drop patients too far as well. So, it gives a much greater variability to a patient's blood sugar, high or low, which can certainly cause some damage and some issues. There may be some rare instances where sliding scale may be utilized. Patients who are sick, they're not eating well. Maybe they're hospitalized with a lot of acute problems going on. But again, generally not recommended for kind of a longer, moderate to long-term strategy for blood sugar and diabetes management here. Adverse effect profile with insulin lispro and virtually any insulins, I guess. Hypoglycemia. Anytime you give insulin, it can drop blood sugar too far and cause hypoglycemia. So that's definitely probably the number one thing to look out for. Insulins can contribute to some weight gain as well, so that can be a challenge there too. All right, the last medication today, number 65, is valproic acid. Mechanistically, this medication helps increase or stimulate the inhibitory neurotransmitter GABA, and that can potentially be useful in bipolar disorder, seizures. Valproic acid sometimes used for migraines as well. In my patient population, I don't love to see it, but I see it occasionally used for aggressive type behaviors, and that's an off-label indication, obviously. How well it works and the efficacy of that, it's not incredibly strong, certainly, but I do see it there occasionally. Side effect profile, as you could imagine with kind of any medication that's potentially used for preventing or reducing seizures, CNS depression, sedation, confusion, those are definitely probably the most common adverse effects. GI adverse effects can happen as we encounter toxic levels, of course. That typical target range for drug levels with valproic acid, which certainly are measured, is in that 50 to 100 range. Some rare adverse effects, kind of maybe independent of those elevated drug levels. We can see some potential negative impacts on platelets. That is something I've seen in practice, as well as elevated ammonia levels. Hair loss has been associated, and it is more likely to contribute to weight gain as well. LFT elevations, that's an important one to remember, definitely one that I've seen come up on exams and things of that nature. Which, good reminder, if you're looking for any sort of board certification study materials, go to meded101.com/store. We've got tons of resources there, Amazon bestsellers, review courses, and so on and so forth. So don't hesitate to go check that out, and obviously support our sponsor, meded101.com. With that said, the other thing I wanted to mention with valproic acid is a drug interaction with lamotrigine. I have seen these medications used together occasionally. There is a significant increase in the risk for that lamotrigine rash if valproic acid is used together with lamotrigine. And then last but not least, there are numerous dosage forms with valproic acid, and I'm not going to bore you with going through all of them in this podcast episode. But the really, really important thing to know is if you switch dosage forms, that bioavailability and what gets into the bloodstream can vary. And so basically what this means is that if you switch to a different formulation, you're likely going to get a different kind of steady state blood concentration with this medication. So any type of switches with dosage forms, particularly in a patient where we're sensitive with what the level is. So let's say seizure disorder, for example, you really want to pay attention with those dosage forms. It's definitely something I've seen done probably more commonly in error, where the wrong dosage form has been given, which could maybe throw off those drug levels slightly. So certainly pay attention to that. All right. Well, I think that's going to wrap up the podcast for today. Do me a huge favor. Leave a rating review on iTunes or wherever podcast platform you're listening on. I greatly appreciate that. Share us with friends, colleagues, of course. Reach out to me at mededucation101@gmail.com. Support our sponsor, meded101.com/store. All your purchases there go directly to support this podcast. And of course, you can track me down on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. With that said, all these medications have been covered in depth in previous podcast episodes, so don't hesitate to go to reallifepharmacology.com, search up those medications, and learn a little bit more in depth and in detail about those medications. So, and with that said, I've also got the top 200 study guide, which you can get free at reallifepharmacology.com. Simply an email will get you access to that as well. All right, with that, I'm going to sign off. Thank you so much for listening today. Take care, and I hope you have a great rest of your day.